Yeah, I was born and raised in the Philadelphia area, going to medical school at Temple in Philadelphia. And I've been in Boston ever since I finished medical school, except for 2 years at the NIH. And I'm currently an emeritus kind of guy, having completed tenure as neurosurgeon in chief at Boston Children's Hospital.
Great.
I'll bet this is a question that most of people answer the same way. I think my first mentor was my chief resident, Chuck Rich, who was just a prince of a person, who is now in practice out in, well, was in practice in Salt Lake City. He's retired now too, and was just a wonderful man to learn from. I would say the other important mentors were in my MGH residency, along with Chuck. C. Miller Fisher, I don't know whether you know that name, Kurt. He's a famous neurologist who described so many very important syndromes in vascular neurology. And I spent a month on the stroke service as a neurology resident as the first part of my neurosurgery rotation. And it was the most instructive period in my residency, learning about how one observes and one records patients and learns from them. Bob Ogeman, who was the neurosurgeon there on the staff at the Mass General, a patient, careful, kind man who didn't throw things in the operating room like everybody else did in that era, and who taught me by example. He had an incredible bedside manner and could deal with referring physicians in ways that I never saw anybody else do. And I would say finally, Ben Stein, who was, as you probably know, being in New York, Ben was the head of the department at Columbia, but my very first job was at Tufts, and Ben was the chief at Tufts then, and he hired me there and gave me full reign to do pediatrics, to do vascular, sent me to Switzerland for 3 months so I could work with Yasher Gill as a young kid, and taught me more about skills in the operating room than I think I ever learned during residency in that first year or two in practice. This is a very interesting question to ask anybody my age. I mean, I think, and this comes from my father, who was a neurosurgeon. He always said that the legacy that he left behind would be the patients he took care of, whose lives had been prolonged or extended, and also the students and residents he taught, whose careers would live on after him. And that's one area I definitely feel is very important, especially in pediatric neurosurgery. I mean, I just love my practice and love the patients. The second area I think is in having picked some particular case problems when I was a resident. There were cases I saw that I didn't understand or hadn't recognized, and I sort of grabbed onto them and made them career interests, and they lasted my whole career. And those were moya moya and cavernous malformations, both of whom I saw the first cases I'd ever seen when I was a resident at General and didn't know what they were, and said, I'm going to try to understand these. And it turned into career-long interests that really were responsible for a lot of my professional reputation. That is a very difficult question because I like so much of what I did, but there's something about the routine of certain cases that's reassuring. And I certainly loved Chiari decompressions. I loved the anatomy in the posterior fossa, the structure of the picas, the cerebellum, the fourth ventricle outflow, the vertebral arteries, the cranial nerves you could see there on occasion. That operation, I think I really enjoyed. But I also enjoyed the moya moya surgeries because that had a routine and a pattern to it that was like nothing else I had ever done. And it involved a microscope, and it involved also a routine, which there's nothing like a routine in surgery. I guess instrument actually is the Penfield dissectors, and which I used again and again and again. And we're not talking about necessarily micro instruments. I used the Penfield 1 and the Penfield 4 all the time. And those were really my go-to, aside from the things that we all use, like the bipolars and suction. But those I think I would be lost without. One to me that is, I think, very important is the neurosurgeon's treatment of malignant gliomas. Uh, there has been so much in our literature about this topic over the past 4 decades that I've been in. I've been in actually in neurosurgery 5 decades. And the amount of progress that we've made in surgically treating malignant gliomas, I think, has been minuscule. It's obvious to me that this is not a surgical disease. We can operate to remove tumor mass and to improve symptoms and to make patients feel better, but we're not going to cure these tumors by total removal of them. That has been shown again and again. And I think that it's time for us to stop concentrating on that and publishing articles about it and new dyes to help pick up tumors at the tumor cells at the fringes of resections, because that's not going to be the answer to these tumors. I suppose the other issue that I feel very passionate about is surgeons feeling that surgery is the only answer to the treatment of the patient with a neurosurgical disorder. I'm so often the neurosurgeons don't think about the whole patient, and they don't think about what the effect of surgery and an operation or a stay in the intensive care unit is going to mean to the life of a patient and to that person's life and to the family's life. And I think people have to think more about what we actually do as surgeons and whether it makes a difference in the patient's life and whether it has a deleterious effect on their last months of existence. And that is thought of all too rarely. And my favorite non-medical hobby is easy, and that's piano playing, jazz piano. I play piano virtually every day, and there's a piano right here behind me. And the I have a couple of jazz groups I play in. We have a neurosurgical jazz band, and which we play it when meetings were live. We played at usually most of the major meetings around the country, and I have some groups I play with here in the Boston area, and I'd be lost without that, Kurt. So that's something that's been a part of my life since I was a 5-year-old boy. Two things. One is making sure you keep very good records, and I'll tell you, that's important. Making your data, everybody has to have a database, right, for their logs. And when you're going for your boards, you have to have a database, but you have to think about this and set something up on your own so that you can add to it as you're following patients, because that's going to be a resource you're going to come back to and use when you're in practice and you're writing papers. The second thing I would tell a new resident is to think about becoming an expert in something that interests you as you're getting into the residency. As I mentioned to you, two of the things you asked me earlier on, what were my biggest accomplishments or what am I most proud of? And I said it was seeing patient problems, trying to figure out what was going on, and telling myself, I'm going to learn more about this, and I am going to become an expert in it. And becoming an expert in it meant, even if I didn't know much about it, giving talks about it, preparing papers about it, checking the literature, and so that when the topic came up, I knew more about it than any of my fellow residents did. And those two topics became career-long interests because of experiences I had when I was a young resident.